Thank you, everybody, for coming. It is my pleasure to introduce our speaker for today, Erica Sedlander. Erica is an assistant professor I just wrote this all down because it's long, in social and behavioral sciences at the Institute for Health and Aging in the School of Nursing at the University of California, San Francisco. So I like rivals our titles here. Erica received her MPH from University of California, Berkeley, and her DrPH from George Washington. And she has really worked across a lot of very relevant issues for women's sexual and reproductive health. So she started a lot of her work measuring and validating scales on gender norms, and then moved into understanding the relationship between concerns about infertility and contraception, and has really moved on from there to really focusing on infertility and its relationship with both HIV, but also infertility on its own. And her work is, I think, exclusively in international. Is that right? Yeah.
Soon to pivot to the US.
Soon to pivot to the US, where there is great need. So it is my pleasure to introduce Erica, and I let you take it away.
Hey everyone, good afternoon. Thank you for the invitation. It's nice to be here and to share my work with you all. I'm based in Washington, D.C., so I'm mostly working remote and spending a lot of the day on Zoom, so it's nice to see you all humans here in person. And just to share my work that I'm excited to get your feedback on, and we can also make this informal. I'm not sure how we're doing the chat, but in the room, if people have questions or comments as I'm going through, you're welcome to raise your hand and I can stop, and we'll of course have time at the end. So what I'm going to be talking about today is really reframing infertility from treatment to prevention. So oftentimes when people think about, is the camera okay? Good, okay. Intuitive with it. No. So oftentimes when we think about infertility, especially in the US context, we think about IVF or advanced reproductive technologies. But from a public health perspective, I'm hoping we can kind of reframe this and think about infertility from a prevention perspective, from a public health perspective, which is what most of us do. And today I'll be focusing on one very niche aspect of that, and that's thinking about harnessing fertility desires in women living with HIV, and encouraging them or understanding what they perceive about taking medication and how that can help them get pregnant. And that's one really niche example, but it can also apply to other health behaviors that affect fecundity or infertility. And so I hope that this one example will kind of highlight it, but just really the idea is to think about infertility as a public health problem. And before I go into it, I definitely need to thank my team. This is Team Science. And so my team hails from Sydney, Australia, Nairobi, Kenya, San Francisco, California, and New York. And I have mentors and staff and students that are all a big part of this study. And my work is informed by really one framework, and that's the reproductive justice framework. And many of you may be familiar with it. There's 3 tenets. The first is the right to have a child. The second is the right not to have a child. And the third is the right to parent in a safe environment. And in our field, in sexual and reproductive health, most of our efforts are put into the right not to have a child. A really important right to use contraception, to have access to abortion, to prevent having a child if you don't want to. But just as important, in my opinion, is the right to have a child. And so, so all of my work is really framed with this in mind. And I was just in a meeting before this saying it's not a pronatalist framework. It's really the framework that everyone has a right to have a child. So not to have a child and to parent in a safe environment. And so as Lene kind of alluded to, I just wanted to give you a sense, especially for students in the room, about how my prior research informed the work I'm doing right now. I originally started at GW during my doctoral degree studying barriers to contraceptive use. was a Gates-funded study, as probably many of you have worked on, and we were trying to understand qualitatively and quantitatively barriers to contraceptive use. And over again, it was this fear of infertility, that if I take contraceptives, I will be infertile. And that fear of infertility outweighed taking contraceptives. So having unintended pregnancy was by far better than the potential down the line of being infertile. And so these qualitative accounts, and we did a social network study, we did quantitative work in Kenya and Ethiopia, and so I just got really obsessed with this belief because women cared so much about it. And then at the same time as I was reading this data in different presentations, I myself was also going through IVF, and so it became more and more apparent that making sure that women could have a right to have children, given my place of privilege in Washington, D.C. with access to an IVF clinic, was really important. So that's kind of moving from the belief that contraceptives cause infertility, as Lene mentioned, to actually just focusing on infertility and infertility prevention is now where I'm focusing all my research. And so a lot of my work, and many, many others for decades, all across the world, and especially in sub-Saharan Africa, show the value of motherhood and the stigma of infertility. This is true everywhere, but really, especially in sub-Saharan Africa. And so that really kind of underpins a lot of the work that I'm about to present today. So I did some recent qualitative work in Tanzania. None of this is new, what I'm showing right here, but really we all know that infertility can have dire consequences for women, especially in sub-Saharan Africa. So this work in Tanzania, these quotes are saying that if infertile women would often be sent back home, harassed, raped, divorced, or their in-laws would withhold food from them because she was just there to fill the toilet and not giving them a child. Yes, the filling the toilet quote comes up in a lot of qualitative studies, many. And so just to kind of understand how can we reduce this morbidity, how can we prevent this from happening to women across the world? So I thought, can we harness this fear of infertility or the desire to get pregnant to be a facilitator for healthy behaviors? And that's what kind of informed my current work. How can we know this is what women and couples care about more than anything else? How can we use this messaging? We know it prevents healthy behaviors like taking contraception if women don't want to get pregnant, but how can we harness it to encourage healthy behaviors? Things like adhering to your medication if you have a chronic condition, quitting smoking, which we know is attributed to infertility, or losing weight, because we know obesity is associated with infertility as well. So infertility is a missing link in public health in general. It's tied to myriad health behaviors, but it's often ignored in sexual and reproductive health. Even at ICFP, where some of us were in November, there was one session on infertility and another side session. But really, it's one of the tenets of sexual and reproductive health, and it's often ignored and not funded the same as preventing pregnancy. So really brand new 2025, end of 2025, November, right after Thanksgiving, 2025 WHO guidelines about infertility came out. And it's broken up into thirds. And the first third is all about raising awareness about infertility causes to prevent infertility. So I was really excited to see that there's at least a global call in the first WHO infertility guidelines, really focusing on this important piece. And so, as I mentioned, a lot of times high fertility settings the funding is focused on unintended pregnancy, and in lower fertility settings, like ours, like the US, we sometimes think about more affluent women who are able to pay out of pocket for IVF services or for infertility services. So when we think about these two different settings, I'm trying to think about who's left behind. And can we reframe infertility with a public health lens as a disease, which it is, to prevent on a population level? That's the whole background. Now I'll go into the studies. But just so you have definitions before we go into it. So infertility is defined by the WHO as a disease of the male or female reproductive system, defined by the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. And subfertility is an extended period of unwanted non-conception without confirmed infertility. So very similar, but less than 12 months. And then fecundity, which is mostly what I'm going to be talking about today, is the biological ability to conceive.
Can I ask a question? So WHO talks about disease. So what if you're infertile because you're having sex the wrong days?
Still considered a disease. I mean, by definition, but
It's not a disease.
I think, well, I guess, benefit. It's true. Like, so that's why one of my arguments will be if we can understand infertility, the cause of infertility, including having sex on the wrong day, potentially prevent a lot of infertility. But it's a good argument why it might not be called a disease. On the other hand, by calling it a disease, which is a WHO decision, it can get reimbursed better. It can be taken more seriously. But I see your
It's an advocacy strategy.
Exactly.
Okay. Okay, thanks.
I'm guessing. I don't know the reason why the WHO decided to call it disease. So the factors that cause infertility are quite complicated. When I move from understanding contraceptive use to infertility, there's a lot to learn. It's not like taking a pill or inserting an IUD. There's a lot of factors, and we're learning a lot about it. But there's mostly medical research on infertility. There's very few. I'm a social scientist and a behavioral scientist. There are very few of us working in the infertility space. All my mentors at UCSF are all medical doctors with expertise in kind of the medical side of infertility. And so anyway, but I'll go into some of the factors and causes of infertility. The first, which many of you probably know, is sexually transmitted infections. And they're the most common cause in sub-Saharan Africa. And as you all know, they're preventable with barrier methods, and they can be treated. So things like chlamydia and gonorrhea that cause pelvic inflammatory disease can then block your fallopian tubes and cause infertility. Other causes are endometriosis, polycystic ovarian syndrome, and then what I'm focusing on today are chronic conditions that cause inflammation and endocrine disruption. So things like HIV, type 2 diabetes, and obesity. And also smoking is associated with infertility. And the last piece is just something that most people in the world probably don't know, is that both male and female factors contribute equally to infertility. So we look at all of this, a third of infertility is also unknown, but there are some behavioral changes that can take place to prevent infertility. That's what we're focusing on today. And the theoretical underpinning of this work is the life course framework from Michael Liu, who at UC Berkeley was really ingrained in us. And so the life course framework goes beyond comparing exposure to risk and protective factors at one point in time. So rather than thinking about the ability to conceive when couples are trying to conceive, thinking about protecting your fertility throughout your reproductive life course. So this work is about preventing infertility by promoting factors like adhering to medications for chronic conditions, which is what I'll be focusing on today. Okay. Pause there for a second. Now I'm going to go into a quite niche topic, which is HIV, antiretroviral therapy, and fecundity. So in this work, there are 2 ARTs in the presentation, which is somewhat confusing. You have antiretroviral therapy and assisted reproductive technology. For the rest of the talk, I'm going to be talking about antiretroviral therapy, which is in sub-Saharan Africa, people with HIV have to take a daily medication. When they have HIV. In the US, there's longer acting antiretroviral therapy. I'll say it out loud because I also have a pet peeve about acronyms. But if it gets overwhelming and you say, you can say ART, I'll just start doing that. Okay, so Fortunately, given advancements in antiretroviral therapy, women living with HIV, they can safely conceive and you can give birth without vertical transmission. Vertical transmission is not passing it along to your child. You can also breastfeed as long as you're adhering and you're suppressed. So in 2022, a WHO meta-analysis reported that 1 in 6 couples worldwide experience infertility. But what had already been known was that women living with HIV face even higher infertility rates. You can look at these citations that's been going back to 2016. And Alison Gemmell was also published on this in 2018 using DHS data and looking at fecundity in women across sub-Saharan Africa. So longitudinal studies also show that antiretroviral therapy improves a woman's ability to get pregnant. And men even show improvement in their sperm quality after 6 months on ART. So despite strong fertility intentions and antiretroviral therapy's critical role in improving fecundity, there's really little attention in the ART education space. So there's a lot of education when people have HIV about adhering to their antiretroviral therapy. That's huge. It's the most important thing to do. But there's really very little in the literature, which I'll show you, and what we found around harnessing this information to improve antiretroviral therapy adherence. And then ultimately, what brought me to this topic is to help women achieve their reproductive goals. And this is important. Important because 73% of people with HIV worldwide are virally suppressed. So 27% of people are not. And so this is a missed opportunity, given especially we know that this is probably the #1 thing that women want in sub-Saharan Africa, and the majority of people with HIV are in sub-Saharan Africa. So this, on a population level, it's quite a small message, but it could improve adherence and help people reach their reproductive goals. That's my hypothesis, that raising awareness of antiretroviral therapy improves fecundity, could increase adherence, and help couples reach their goals. And for the kind of more epidemiologists in the room, just to give you a sense of how HIV affects your fecundity, how it affects your reproductive system. So elevated infertility risk in women with HIV, it's largely related to immune and endocrine system dysfunction. So women with HIV have increased rates of prolonged anovulation and amenorrhea, increased risk and severity of other co-infections that can cause infertility, things like chlamydia and gonorrhea. And then in men, they also have sperm abnormalities. So men on ART show improvement in sperm quality after 6 months. It's a little bit less understood because antiretroviral therapy also affects sperm quality, but studies have shown that the sperm quality improves, even though the sperm is affected by both the medication and the virus itself. And that affects things like motility and quality. So we have all of this data, longitudinal studies and medical studies showing that we have these evidence-based studies, but it's not translating into education, into the general public, and as I'll report soon, even into providers' knowledge. So before we went into primary data collection, we just wanted to understand the literature. And I also wanted to learn how to conduct a systematic review. I'll never do one again, but it is long. But I do feel very confident in knowing this literature now. So we did a systematic review to understand perceptions about the relationship between HIV, ART, and fecundity in sub-Saharan Africa. We concluded studies from 2000 to November 2024. And it's still not published, but it's almost there, second R&R. And so when we conducted this with our search, we initially got 2,000 studies. And then after removing duplicates and screening almost 2,000, there were only 32 that had anything at all related to perceptions about HIV, ART, and fecundity. The majority were all about preventing vertical transmission or mother-to-child transmission, and also ensuring that people living with HIV know about how to safely conceive with serodiscordant partners. And that theme also is will run through when I present the results, that's really what the field is focused on now. And so after going through the papers, we ended up with only 17 that had anything to do with perceptions about HIV, ART, and fecundity. And when I say that, it was really just sometimes one small quote, or not even a quote, like a reference within the discussion. So we found that there's really a scarcity of literature on people's understanding of this relationship. And so, and just briefly, what we found was that there were, when I say beliefs, there were beliefs that HIV and PrEP can cause infertility, but that was one study for each, and just a reference, not even full study, just one referencing it in one study. It's like the PrEP vaginal ring, they said that might cause infertility, and one brief mention of HIV potentially causing infertility. There were perceptions that ART improves health before pregnancy, and that motivates women to adhere. But that's really that was more about hope about future pregnancy to not pass it on to their child. So it wasn't even exactly our research question. And we found that stigma from providers discourages women living with HIV from seeking preconception care. And that will also be part of our results, is the stigma around HIV is, as I'll present, is kind of a barrier to thinking about fecundity. And then lastly, there was a lack of awareness among providers and patients about the impact of HIV on pregnancy, highlighting a need for training. But again, these were very, very short references. So now I'll go into the current study that we conducted. It's a qualitative study among men and women living with HIV and the providers who care for them in Kenya. And again, same topic, perceptions of how HIV and antiretroviral therapy affect fertility. And so we wanted to understand perceptions among men and women and providers. We wanted to examine how providers discuss this relationship with their patients. And then we wanted to document suggestions for raising awareness about this relationship to improve adherence and help couples reach their goals. So this took place in Kenya, outside of Nairobi, where the HIV prevalence is a little less than 3%, and which is lower than the national average. So qualitative study with in-depth interviews. We included 30 participants, which was lower than we originally planned, and I'll explain why at the end. 20 men and women of reproductive age and 10 healthcare providers. And we posed a sampling balanced by gender and age. And then we focused on providers that had a specialty in reproductive health, because we thought that they would be most likely to speak to their patients about this connection. The interview procedures were in-person interviews in Swahili and in English. I conducted a lot of the provider interviews when I was in Kenya, which was really fun. I hadn't done that in many years. And they were audio recorded, transcribed, and translated to English. We used thematic analysis, where we coded as the interviews were coming in. It was iterative, with inductive and deductive coding, and we triangulated post-interview report forms. We wrote memos after each coding, and we created a matrix analysis to visually compare men, women, and providers for each of the emerging themes. And thank you for inviting me for this presentation. It did speed up the analysis. Because we just finished data collection in November. So thank you for moving us forward. And so here are the demographics for the men and women in our sample. We balanced by gender, but it skewed pretty young. Men were on average 22 and women were 28 years old. Most participants were still in married or long-term relationships. Over a third of the participants reported experiencing infertility in their lifetime, which is double what the WHO reports. So we hypothesized that they participated most likely because they were more interested in infertility research. The majority had children, but about a third did not. And for providers, most worked in a public setting or faith-based hospital. They were nurses and clinical officers, physicians, OBGYNs, and they had a lot of experience delivering healthcare, 15 years average. So we found 5 themes that really depict perceptions of how HIV and antiretroviral therapy affect fecundity. Go to the quotes, which are the best part of results. And the results, finally. All right, so the first theme was that most, but not all, which we hypothesized, most, but not all men and women believe there was no relationship between HIV and fecundity. So a woman with HIV, age 21, she said, no, women with HIV don't have a harder time getting pregnant. They're just normal people like others. It's just that I take medication and I have the virus. And so that was really the overall mentality among men and women living with HIV. There were some outliers, like this woman who's 32. I have taken medication, ART, for a very long time, and I still haven't gotten pregnant. Yeah, I've had tests done, I have had everything done, and I'm told everything is okay. So that's why I can say mine is HIV that is not getting me pregnant. What was most interesting, but again, not completely surprising, was that providers really had mixed beliefs about whether HIV affects the country. So these are reproductive health specialists who predominantly serve women living with HIV. And a study clinician said, no, HIV doesn't affect fertility at any point. So they'll be able to get pregnant as any other woman because HIV does not affect you biologically or doesn't affect your semen in any way. Everything remains the same. And a health coordinator corroborated this. They said HIV will never cause infertility and infertility will not cause HIV. Nothing causes the other. It's just in the head. I know so. There was a lot of really strong opinions about this that came out from providers and people living with HIV. And so the interview guide, we ask questions, and then at the end we inform them and then ask them again. So all of these, we know this is just asking their initial thoughts without giving them any education. But then some providers, many more than people living with HIV, did understand this connection. So a clinical health officer said, once the patient is immune suppressed, infections come in so easily. So you can find a woman having issues with chlamydia and all that which cause PID and infertility. An OBGYN said, poorly controlled HIV, AIDS, the wasting, the very low BMI is known to affect the reproductive system. Abnormal uterine bleeding, amenorrhea, all those kinds of things. So the second theme was that perceptions of ART's impact on fecundity were positive, but pretty vague, alongside some beliefs that ART made it harder to conceive. So a woman with HIV said, if you live a healthy life, follow the doctor's instructions, and take your ARTs, the chances of that virus affecting the pregnancy will be nil. It won't affect your pregnancy because the body is healthy, the reproductive system is healthy. And the medical provider corroborated this. They also said there's no research that has been done and has proved that use of ARTs can cause infertility. So of course we won't tell them that. You have to make sure they're taking their medications to improve their health. Because when their health is okay, getting pregnant is easier. But a man with HIV, and there were others, just for time, of course, didn't hold this belief. So he said, I hear most of them say, so this is talking about his belief, but other people in the community, is that medication, ART, when you take that medication, you cannot impregnate or you cannot get a child. So thinking about taking medication and how that affects your fecundity in general appears to be not the main belief, but that could affect your fecundity, similar to vaccines or contraception. The third theme we found was that community level stigma around childbearing shifts focus away from fecundity. So this is kind of what I mentioned, there's a lot of stigma around HIV, and the goal for a lot of providers was to reduce stigma and to tell patients that they are just like everybody else. As long as you take your ART, everything else is fine. You're just, one of the quotes said, and so that really was this focus. And so when we asked about HIV, ART, fecundity, there was a lot of defensiveness that we are normal people, everything's normal, we can have children. The community doesn't always believe that, but this is what we've been told, and this is true. And a lot of providers, folks said that was important to describe to them, to reduce stigma, to make them understand they can live a long, healthy life. So a man with HIV said, my doctor told me that first I should take my medication well, so when I want to have a child, they will be negative. And they also advise you to eat well and have a balanced diet, things like that. And a woman with HIV said the community members think that if a person gets HIV, they cannot have a child. They cannot carry pregnancy like that. At times, they think that someone will die early before giving birth. So there's a big difference in what people living with HIV believed and what the community believed. And they talked a lot about HIV stigma affecting how they thought about how people in the community still believing it was a death sentence or that they shouldn't have children, even though they didn't understood that wasn't the case. And provider perspective on stigma around childbearing also shifts shifted away from fecundity. So a nurse said the community have imposed on them is that if you get a child and you're HIV positive, that child won't survive. And a study clinician, this quote kind of really sums it up. This person said, I haven't had any patient who thinks being HIV positive will impact their ability to get pregnant. Their main concern is, will they get a healthy baby? Yep, that's the question that comes up. And so this mentality of like, can I still have a healthy baby seems to be the dominant conversation, what we found. The fourth theme we found is that provider counseling that included discussion of HIV, ART, and fecundity was rare. So a woman with HIV said, it has never come up. The doctor has never told me. And a man with HIV said, you are told, don't worry, you will get pregnant, your child will be normal. It was just that you would be able to get kids and everything will be okay. So this theme of everything will be okay, take your ARTs and everything will be okay, to reduce stigma, to make people feel normal, to make people feel good, was really what both providers and patients said over and over. So again, this providers also mentioned that they didn't speak about this connection. So a nurse said, mostly it will come from them. They will ask, will we be able to have kids? And then we start from there. We just tell them that it is very possible, but the only thing they're supposed to do is to make sure that they take their drugs. And a medical doctor said, as far as their chances of getting pregnant, we leave it as if it is normal, provided they take their ART. They are normal, they're responding well to treatment, then we have no issues about their fertility. So again, this like very simple message, using the word normal a lot. And the last theme that we uncovered was really this idea of, so as I mentioned in the interview guide, we asked them about their perceptions about HIV, ART, and fecundity. And then at the end of the guide, we let them know that HIV does negatively impact fecundity, but if they adhere to their antiretroviral therapy, it will improve their chances of getting pregnant. And so after that, the defensiveness kind of moved to some anger around why providers hadn't told them that, or how they didn't know. And then on the other side, providers also agreed kind of quickly, yes, we should inform them of that. That should be part of education. That's an important part. So it's interesting in a qualitative setting where you're acting, for 45 minutes about one thing and then educating people and then hearing their reaction. And that's kind of an overview of what we found. But from the patients, from the people living with HIV's perspective, they thought to raise awareness about this connection. They preferred information delivered by a provider, like many studies that I've conducted and probably you have shown, or a peer mentor, which a lot of times people living with HIV have peer mentors who are also living with HIV. So a man with HIV said, I would want them to tell me how it affects me because I have HIV and I'm using ART. If it affects the chances of getting a woman pregnant, it is a must that they tell me why and they explain it. And a woman with HIV, she said, the best way to learn is in a group, because when you're surrounded by people like me who are diagnosed with the virus and you hear their side of the story, and also the teacher teaches you everything, the environment is friendly. I think that's the way it should be. And a medical provider said they should be offered the knowledge and counseling on the same. That if you really want to conceive, even if it's now or later, you want to take your ART well, it improves your chances. So after we told people about this connection, everyone really quickly got on board that this should be part of education. And with people living with HIV particularly, there's a lot of education around ART adherence. And so it wouldn't necessarily be a new setting or creating a new intervention. This already exists, right? And so in conclusion, current provider and patient education is really simple and it's really positive, and that's probably intentional. But the relationship between HIV and ART and fecundity is a bit more nuanced, and so it's a little bit less positive. The less positive piece is missing. That's that HIV negatively impacts your fecundity. And so from a reproductive justice perspective, men and women living with HIV deserve to have this information and to give them the best chance of getting pregnant, given that 27% of people with HIV are not completely virally suppressed. So what I'm arguing, and hopefully we'll get to work on next, is that a discussion around the negative impact that uncontrolled HIV has on fecundity and the positive impact that ART has could improve adherence and help couples reach their reproductive goals. There are 40 million people living with HIV in the world, and probably most of them at some point when they have HIV want to have a child. This very short, small, simple piece of information could move the needle on a population level to improve ART adherence and help them get pregnant. And so that is it for Kenya. Just one slide on moving from Kenya to the US, which is what you just alluded to. So all of this work was funded through a K award from the NIH, from the National Center for Translational Science. But I was asked to move it to the US earlier in late 2025. And so all of the work that I just presented was funded using discretionary funds, which is why the sample size is smaller, and just had to get really scrappy with conducting interviews on my own, finding resources to carry out this work that had already been planned and that I really wanted to do. So now I'm moving to working in the US with this K award. And the next steps I'm doing is developing and validating a scale to measure knowledge about the causes of infertility. All the different, the myriad causes of infertility. And I'm going to be testing this among women of reproductive age in the US. Half of them have HIV and half of them don't. So I'm interested both in the HIV angle, but also now that we're moving to the US and HIV, the percentage of women with HIV is a lot smaller. I'm expanding to all chronic conditions, but also not even just chronic conditions, understanding what causes infertility among all men and women of reproductive age is important, in my opinion. Knowledge isn't everything. We need to change norms and behaviors, but it is one of the important aspects to change intentions around behaviors and seeking diagnostic care. So within the study, we'll then examine the association between knowledge and medication adherence, where knowledge reflects awareness that chronic conditions negatively impact fecundity, but the medication mitigates this risk. Thank you very much to the team from Nairobi, Kenya, after we conducted most of the interviews all together. Thank you.
I guess I'm the moderator. Great. Are there any questions in the room? And we'll start with students first.
So thank you so much for your presentation. First of all, that was really awesome. I think it fills such an interesting niche. And honestly, like it's really interesting to me because I previously worked in HIV care as well. One thing I was thinking about was I was going back to your discussion of kind of the consequences of infertility for women. And it seems like so much of the fear of infertility is like this fear of these consequences that women face from their community and their family, like their in-laws and their spouses. At the same time, I know that for a lot of people with HIV, like having a supportive social network is really important for maintaining adherence. So those two things kind of seem at odds. So I was wondering in your systematic review if you found anything about taking like in trying to raise awareness about HIV and infertility, like including spouses in that counseling so that they are also aware, and so it becomes like more of it becomes like a process that strengthens our social support network in addition to like informing women who are living with HIV who are like navigating their fertility trajectory.
Yeah, no, that's a really, really important point for contraceptive. For contraception, we know we know that bringing in spouses is really important when we want to ensure that women take contraception if they don't want to have a pregnancy. And actually in this work, so this study was kind of we took this qualitative work and broke into 3 different studies, and 1/3 of it is just on in perceptions about infertility broadly and gender norms around what happens when a couple is infertile. So we used vignettes to uncover norms around what happens if this couple in their community was infertile, and not surprisingly, the women was often blamed and people would go outside the marriage. And so, that's a whole other study that we'll publish. And a lot of that came around couples communication and couples care seeking. But within this study, I think there were two, no, it's a small sample. There are 30 participants, and I know the data quite well. And so I think there were two participants who said that they would actually like to have their partner there for information about how it affects their fertility, because men's fecundity is also impacted by HIV, and they might both have HIV, and so just understanding how it affects their couple and getting pregnant is an important point. And ideally, in all the research we do, we always want to include men. And fortunately, we were able to include men in this study. And unfortunately, when I'm testing this knowledge scale, it will only be with them. That's the study that I have access to. But it's a really important point that a lot of people want to include their spouse or need to include their spouse for behavior change. Thank you.
Maybe we'll go here.
I'm curious if you think that this work can be translated to like increasing PrEP uptake, especially like for cisgender women in the US, or if you think that it's too like, if you do this, then like if you take this PrEP, then in the future your fertility could improve, like it's too conditional. Whereas if it's just being used to improve art, it's like more grounded in like a medication that someone's already taking.
Yeah, that's a good question. And at first I thought, yeah, that is a good idea, but and it could still be actually. It's an interesting idea. I would imagine in the US, the risk of preventing HIV is an impetus enough, or is an impetus to take PrEP, obviously. But at the same time, HIV is now a chronic condition, and the fear of infertility down the line could be another lever to increase PrEP uptake. It seems a little bit, it's farther down the line, right? Because they don't even have HIV yet. But I guess if there's campaigns for PrEP uptake and most of them are probably focused on HIV as this negative outcome, and then it could be added to a list of all the reasons why you don't want to have HIV. That said, in the US, if you adhere to antiretroviral therapy, your fecundity is similar to others. But it's a good thought. I had never thought about that.
Thank you. This is super interesting. I'm wondering if, like, assuming somebody has HIV and is on ART and becomes suppressed before they're trying to get pregnant, or maybe doesn't become suppressed. Are you, like, would your recommendation be that it comes from an HIV provider or a reproductive health care provider? Sort of this information, because I can imagine that once people are suppressed and maybe they're experiencing infertility and they go to a clinic, like, well, yeah, you should know that your HIV may reduce your fecundity, but you're already suppressed, so you're doing everything you can already. And so it's important to provide that information, but there's not really like another step to take, as opposed to pre-conception attempts. Maybe that information would be like not coming from a reproductive provider because they're not seeing someone yet. Does that make sense? I'm just wondering where along the care continuum, given that there's probably not that many like HIV fertility doctors seeing the people who are struggling with this issue.
Yeah, no, it's a good question. So I'm thinking about farther, more upstream. So people are already getting, as soon as someone's diagnosed with HIV, they get ART education, and they get it in sub-Saharan Africa. Before USAID funding cuts, they would get ART every 3 months, and so they're going back to their HIV care provider every 3 months, and they're oftentimes getting ART education, especially if they're not virally suppressed. And so that's a really low-hanging fruit place to just insert a brief message. You're not creating another intervention. You're not creating more an additional piece of communication. It's really just, you're already getting this. Why not just change the message, tweak the message, add a brief message? So I was thinking HIV providers for this specific case. And when we asked the HIV providers what they thought about it, we asked them, who should be the messenger, when should we give it, how should we give it, and given that a lot of them didn't understand the connection and a lot of their colleagues didn't, they suggested a CME or continuing medical education around this, and then a brief communication module to ensure that they're saying it using person-centered language. And so I don't think I think probably for this niche intersection, HIV providers would be most practical and resource and not so resource intensive.
Sure. Thanks so much for the presentation, Eric. It was really great. I was wondering, you mentioned a little bit about how the current messaging was focused on, that people are normal, and then if the messaging related to future fertility, was something quite simple, but actually it's quite nuanced. What is your current recommendation on how to approach what that additional counseling looks like in a way that doesn't almost I don't know what the word I'm looking for is, but overcommit to people that they will be able to get pregnant when they want to, if only they do this thing. And maybe it touches on a little bit of what Isabella was saying earlier about kind of these, conditional statements that people won't feel like, I did the thing you told me to do, and now I'm still struggling 5 years later to get pregnant. So how do you navigate? I mean, this is a big question, obviously. How do you navigate that nuance with something that is not so black and white? Obviously, there are the other factors that you mentioned that affect someone's fecundity. So how do you approach that?
Yeah, no, I think it's a good question, and it's what Paul's around is pregnancy. They're probably most of us I read Emily Oster, If We Were Ever Pregnant, and she argued that oftentimes medical language is really simple for pregnant women, but it's actually more nuanced, right? And it's not just if you do this, this won't happen. So, but I think the exact words you use will be really short, and I think having one little card or brochure or something in someone's office where they use really person-centered language that's not, you will get pregnant if you take your antiretroviral therapy, but that really is quite simple, that you have less of a chance of we have to test this out, right, using human-centered design, and make sure it's low literacy and low numeracy, but something like you would want to get pregnant. Are you hoping to get pregnant? Probably, or especially people who do want to get pregnant. Having HIV, it might be harder to get pregnant if you have HIV. But we know that it's harder to get pregnant if you have HIV. People with HIV have a harder time getting pregnant. Fortunately, if you take your ART, your chances increase. But we want you to know that people with HIV do not have the same chance of getting pregnant as someone without HIV. Something really simple like that. That's just off the top of my head.
Great, thanks.
Caroline, and then Saifuddin, and then maybe we'll see if there's
a lot.
Yeah, maybe. Well, I think those are Mary Alice.
Oh, I'm just excited.
Oh, we'll do Caroline, and then we'll do Saifuddin, and then if anybody online has questions.
So I've been thinking while you were talking, I think I might be wrong, but there's an implicit that somehow a lack of adherence is a motivational failure. And I'm not sure that's true. I mean, basically, if you don't take ART, you're going to die is a pretty, or if you don't take your diabetes, you're going to die is a pretty important motivation to take the treatment. I don't think it's motivation. I think that there's many other issues in their lives that are in the way of them being able to take the medication. And so kind of my question to you is, basically, if you don't take your ART, you're going to die. Do you think fertility is something that adds to motivation? I'm just wondering.
I'm not arguing that there's 27% of people who are not virally suppressed worldwide will take their medication if we get this message. Not at all. I think it's going to be a small percentage, but when you have 40 million people with HIV, some large number of people, I think, I hypothesize will adhere to their ART. And adhering to your ART is not binary, right? It's not like I take it or I don't. We're talking about missing doses. And so for some people, as my research, as some other research has shown here, motherhood is the most important thing in their life, and potentially, that could be more, not being a mother, it could potentially be more scary than death for them, because that in their community, it is so revered. And so I do think that, there's many factors. There's structural factors, there's transportation factors, there's so many factors. And of course, this will not solve most of those. Not, but on a population level, I think it could move the needle just a bit. And it's so low resource intensive, and so we can test it, right, and see if it is effective, and and I think people also have the right to this information, that not just painting their, I think it probably came from a good intention to say you're normal if you take your ART, and there might be some even negative ramifications, like anxiety producing, if people then know, oh, actually, I thought I was normal, but now I know HIV does impact fecundity a little bit. There's been some research about that in the US when providers have given information about, advanced age for fertility, and anxiety can go up briefly a bit, but behavior also can change. And so I agree that it's not going to, change that 27% of people's ART adherence, but it might change, a little less than 1% of that, and that's still thousands of people. And I think they deserve to have that information, even though it's more nuanced and complicated.
Well, you set yourself up to a great study, right?
Erika, thank you so much for your excellent presentation. Just a curiosity. Promoting ART compliance based on infertility messages, whether can brought unwanted consequences on discordant couples. In a way, let's say that somebody is using condoms for prevention of HIV, and now whether this message can bring some caution.
So serodiscordant partners or serodifferent partners can, safely conceive without passing HIV to their partner. And condoms do help prevent infertility by preventing sexually transmitted infections. So I think if a couple, even if they're serodifferent, wanted to have children, I'm not sure this messaging would change.
Particularly for the discordant, if the couples are discordant, whether that would be a problem or not. Or whether the message should be different. If somebody is discordant or the couples are discordant or not discordant.
I think so, because discordant partners can safely conceive and have children without passing it to their partner. So I don't know how it would, if they decided they wanted to have a child, I don't see how they would have to stop using condoms regardless.
There's a chat question. Yeah. Just because it's on the same exact vein, a student in the chat asked, did any of the women express nervousness about having unprotected sex to get pregnant in fear of spreading the virus despite being on the ART? Was this handled or counseled?
No, the participants we interviewed were very aware that you can safely conceive and give birth without vertical transmission to your child or to your partner. So for them individually, they were all aware of that. They talked about community beliefs that people might die or pass on to their child or give it to a partner, but they had been informed that you can safely conceive and give birth with a serodifferent partner or not pass on to your child.
So you mentioned how after the education intervention, providers were quick to accept that change and agree that this is an easy kind of addition that we can make to our HIV counseling. I'm curious, what reasons did they cite for not previously having that in place? Was it a lack of knowledge on their part, or is it time constraints with wanting to reassure patients about their fertility? Why did they not have it there already?
Yeah, that's a good question. A lot of it was knowledge. Most of the providers didn't know this. The ones who did, they said they used really kind of simple messaging, like taking ART will help you get pregnant. And they thought that was sufficient. And that was just communicating without having to kind of go into the nuance of the fact that HIV reduces your fecundity. They thought that just telling, in their opinion, they said, oh yeah, I am telling them that. I'm telling if they take their ART, they'll be more, they'll have a healthy pregnancy, kind of. So it was just really simple messaging. And so then once we kind of discussed this relationship, they then got on board, all of them really, that could be that could be a part of their messaging, and that it wasn't going to take more time, and that it could be a continuing medical education, that they already do group education sessions anyway. And so it really wouldn't take much time. It was a knowledge thing, and also just not thinking that they hadn't included, for the providers who knew, they thought what they were doing was enough. But then as they kind of thought about it more, a lot of them were like, yeah, we can add this education piece into our existing education. So there wasn't anyone who said we wouldn't have time to do this, we don't want to do this, this is irrelevant. And we had 10 providers, so a small sample of all 10. Originally, the study was going to be twice as big, but with discretionary funds, this is what we scraped by.
Any other questions in the room? Any other questions online? Okay, well, that was a very robust question and answer time, and we are pretty much perfectly on time. So thank you very much.